Thank you. Thank you very much, Dr. Apsi, for the invitation, for the organizing committee, and for the opportunity to be with you today. Such a great pleasure to be in Saudi Arabia. This is my first time, so it's been amazing, and everybody has been wonderful. So thanks for the invitation. Here are my disclosures. I have nothing really, these disclosures has nothing to do with what I'm gonna say. So what I would like to cover in the next 30 minutes or so, I'll start by talking about what do we mean by machine learning, deep learning, AI, and why today. And then I'm going to talk a little bit about the application of AI in hematology. But then I'll move to talk about the future, and the future is generative AI, or what we call it Gen AI. So I'll explain what that means. And then we'll talk about ChatGPT and its application in healthcare, and finally talk about a new initiative with AI for healthcare. So what do we mean by artificial intelligence? So artificial intelligence is making machines things and do things like a human without explicitly programming the machine. So if a human can drive a car, can I make the machine drive the car without me telling all the instruction to the machine? Now, under this big umbrella of artificial intelligence, there is machine learning. And machine learning is training algorithms with data. There are two types of machine learning. There are supervised learning where we know the answer. So let's say I'm trying to build a model to predict a dog or a cat image. I know the answer, this is a dog, this is a cat. I build the algorithm and then hide the answer from the algorithm and say, is this a dog, is this a cat? That's supervised learning. Unsupervised learning when we don't know the answer. So we ask the algorithm to find patterns in the data, come up with the answer to us. An example of that in healthcare is RNA sequencing when you do clustering, for example. And then a subset of machine learning is deep learning, and that's what we call a deep neural network. And these are mathematical modeling of the neurons in the brain. So in our brain, we have the neurons connected, they fire up, and if we try to mathematically model that, that's deep learning. But really, the simplest way to think about machine learning is that you have an input. That input could be a tabular data, an Excel sheet, could be an image, could be a video, or combination of all of this. And you have an output, something you're trying to predict. So classification problem, again, is a dog or a cat. Regression problem is a continuous number. So I'm trying to build a model to predict the house prices in Jeddah, for example. And then in between, there is an algorithm. That could be a machine learning algorithm or a deep learning algorithm. So it seems today that AI is very new. In fact, it's not. So the first time that this terminology came about is 1950 when Alan Turing and his colleagues met in UK, and then they said, okay, we can have computers now, and computers are going to rule the world. And you will see this hype going up and down. At that time, you go like to the movies, and everybody like, now machines will rule the world. Now, at that time, they didn't have what we have today, and it went to this cold period of AI until 90s, in 1997, when Deep Blue beat Kasparov in chess, and everybody was like, now machines are going to take over, and humans are gone. But then that's also didn't really happen until 2016, when DeepMind AlphaGo beat the Go champion. Now, why this was important? Because in chess, you have about 36 moves per move, or 36 possibilities. In Go, you have 200 possibilities, which means you cannot program anything like that. So in each of those, you see this spike on hype, and the new hype now is ChatGPT. Now, behind ChatGPT is what we call generative AI, which I'll talk about. So why today? There are several forces that drive what we see today. The first one is big data. So for the first time, we start having a lot of data, especially in healthcare. So if you think about genomic data, electronic healthcare record data, radiology data, this is a huge amount of data. The second force is actually computational power. So if you think about computers, they used to be the size of this room. Today, you have a computer in the size of your hand, which is the iPhone. Now, if that trend continue in 2025 to 30, you can go to Best Buy in US and buy a laptop that has computational power of a human brain with $1,000. In 2050, you can buy the same laptop that has computational power of a human race. Now you can talk about your kids' homework getting very easy at that time. But this trend, what we see between big data and computational power, and we start having actually some successes. So in terms of the FDA, we start actually now having 500 cleared algorithms. Those algorithms cannot operate on its own. You have to have a human operate with the machine, and then you have some AI-designed drugs that start actually going to the clinic. So how can we use AI in hematology? I'm going to give an example of some of the research that we have done in the past for myelodysplastic syndromes, but the concept can be applied to anything. It doesn't have to be applied to MDS. So if you think about MDS, the way we diagnose the disease, you take a bone marrow biopsy, you evaluate for dysplasia, and then the next stage, you stage the disease, and this is blood cancer, so we do blood counts and cytogenetic analysis, and then we calculate IPSS or IPSSR, and then we try to make a treatment decision based on the risk of the patients. Higher risk patients receive transplant or azacitidine, and lower risk patients get supportive care. So the purpose of technology to solve the problems, now what you can say, do we have problems in this paradigm? We have a lot of them. So diagnosis in MDS is very subjective, meaning even in our hand, when I was in the Cleveland Clinic, about 20 to 30% of patients referred to us diagnosed with MDS. They don't have MDS and vice versa, because diagnosing dysplasia is very difficult on the slide. Now, staging is interesting because what we discovered through a lot of research that what we predict in terms of outcome and what the actual outcome of the patient is completely different. So there is a lot of heterogeneity in the patient and their outcome. And then today, even this is not an MDS, in cancer in general, we give chemo and we have no idea which patient can respond. So we have uncertainty in predicting response or resistance. So can we solve some of these problems using AI? So this is again a study to show that if you take a bone marrow biopsy, you showed those myeloid cells to multiple pathologists, there's a lot of discrepancy between whether the pathologists say this is plastic or not, and you see that discrepancy in the color between blue and orange. So this paper came out in 2017. What they did actually, they took melanoma images and they trained these deep learning model called Inception version 3, and then the question was, are these images malignant or benign? And they built a system that achieved accuracy comparable with dermatologists. Now, this is why we live in the best time in human history to do biomedical research, because we don't have to reinvent the wheel. You can tweak the first layer and change the melanoma images with bone marrow biopsy images from patients with MDS or AML or any type of cancer, and tweak the last layer of this deep neural network and say, is this MDS, normal, or AML? And you see a lot of examples of the use of computer vision. Now, what we ask, actually I should go back, do we really need a biopsy? Can we diagnose the disease based on the blood counts? So we did this international collaboration where we took patients' clinical data, so this is CBC with differential, and next generation targeted deep sequencing for patients with MDS compared to other myeloid malignancies. We trained a machine learning model, and then we extracted features. Feature extraction, meaning we asked the algorithm, what are the important variables that impacted the algorithm decision? We plot those variables to make sure that these variables are clinically relevant, and then we build the final model. So this is the patient population that we got, and the training cohort was from Cleveland Clinic and University of Pavia in Italy, and we externally validated the result from data from Munich Leukemia Laboratory, and you can see we can actually predict MDS from other myeloid malignancies with very high accuracy of 95%. But more importantly, the system was personalized, meaning we have explainability of the result. What you see here on the slide, the machine will tell you this patient has MDS, but this is why. Or the patient has CMML, but this is why. What about prognosis? There are multiple prognostic models in MDS, as you can see here, where we use blast, cytogenetics, and cytopenia with different degree of cutoff. Recently, we have the IPSSR molecular, which was incorporated molecular data into the IPSSR. Now, the problem in heterogeneity, that's across even IPSSM, by the way. So if you take about 1,500 MDS patients, you plot them on this slide. On the x-axis, you have the staging by IPSSR, and the y-axis, you have the survival. So if you look at the median, which is the sort of the cut in some of these, yes, the median survival for patients with low risk is better than intermediate risk, but if you look at each patient as a dot, you see patients in green, patients are alive, and in orange, patients who are dead. You see there are patients in low risk, actually. They have worse survival than patients even in high risk. And if you look at the intermediate risk in the middle, you see all patients all over the place, which means what we predict and when the actual survival of the patient is completely different. So we ask a question, can we build a model that predicts survival that is personalized, that is specific for a given patient? So what we did, we took demographic, clinical, and genomic data. That was another international collaboration between Cleveland Clinic and Munich Leukemia Laboratory, where we trained the model. And it's very important always when you build a machine learning model to externally validate the model in data that is completely different and unseen. So we validated the model from Moffitt Cancer Center. We also validated the model from 3 other cohorts, one prior to transplant, one during the disease, and one from clinical trial. I'm not aware of any model published where you have 4 external cohort validation prior to publication. We build this machine learning model, and the model extract the features. And this is the clinical feature and the genomic features of the model. And as you can see on the right, there's improvement in the C index compared to IPSS-R, even when incorporated molecular data. Now, what was really important, how do you use the model? So what we did, we deployed the model on this user interface. And what you see me doing here, changing the clinical variables for the patient, and then hit calculate, and you see the survival sort of change to be personalized for that patient. Now I'm adding more like worse features. I'm adding very poor cytogenetics and TP53, and you see the survival is more personalized and changing. So why this is important? We went back and we took data from the SWOG study. So this trial was designed for newly diagnosed MDS with high-risk IPSS, treated with AZA versus AZA plus LEN versus AZA plus vorinostat. You can see the trial was negative. Now, when we looked at the data coming from that trial, we had 75 patients who had clinical and genomic data where we can apply the new prognostic model. And what's really interesting, this trial was designed for high-risk MDS. In our model, 68% of those patients actually lower risk, not higher risk. And if you look at the overall survival on the right, patients with lower risk, actually, by our model, their survival was doubled on azacitidine. Where patients with high risk by our model in the second line, you see their median survival actually with azalin was much better than azacitidine. So the question, did we get the right patient to get the right treatment on the trial? And have we chosen the right patient? Would have been this trial positive? So what about predicting response? We use azacitidine, and about 30 to 40% of patients respond and take about 6 months. We have no idea which patient can respond. So the question at that time, can we build a model to predict response or resistance? Today, we don't have any clinical models to do that. As a fellow at that time, and you can play trick with your mentors, you ask, what movie did you watch last week? And then the question, what movie they're gonna watch tonight? And then if you switch mentors with patients and movies with gene, can we use the recommender system algorithm to predict response or resistance to chemotherapy? So we did this exercise, and we were able to find those genomic biomarkers that predicted resistance in 93% accuracy on a validated cohort from outside of Cleveland Clinic. What was really important about this, we went back to the lab and actually we looked at those gene mutations, and we were able to show that some of those combinations are primary resistant cells in the lab. Then we asked a different question, can we predict response to chemo by actually monitoring the count? So we give azacitidine, the blood counts a change. Can we monitor the changes in the counts and predict how the patient will respond? So what we did, we used something like Siri use. So for Siri to understand the words, the sequence of the words matter. So we use the same sort of analysis to actually take blood counts on patients with azacitidine for 12 weeks. We build machine learning algorithm. Again, we extracted the feature, and we built the final model. And what you can see here, we were able, based on the first 3-month CBC changes, to predict response at 6 months with very high accuracy. That's precision recall in about 83%. And again, the model is explainable. What's interesting about machine learning, you can put actually a lot of variables, and then the most important ones sort of on the top. So if you look here for the non-responders, for example, if you look below, RDW is a very important factor to predict no response, even though in clinical practice I've never looked at RDW. So you can see those blue lines predicted no response in RDW. So if you look what the algorithm is chewing on, it's a lot of variables that we as physicians don't even look clinically. So what about the future? The future is generative AI. So what do we mean by generative AI? This is the buzzword today. So generative AI is generating something from something. So text to text. I can give a model a text like ChatGPT, and then I get a text summarization, text generation, conversational question and answer. It can be text to an image, so I can give a prompt to draw a picture, and then that's give you sort of the picture. Could be text to video, and could be text to code. So I can write the text and provide a video. Now think about this in the future. You can generate the text, for example, using ChatGPT, and then generate the entire movie using the AI model. It could be actually the other way around, could be image to text. So I can give the model an image and can give me the text on it, and I can do some image modification, as you can see here, of that. So this is sort of the future that's gonna change a lot of our lives in general, but also in research. Now, I thought I'll have a mouse here to play these videos, but these are AI-generated videos. I don't know if we can play the second one. If you just click on it. Here we go. So the first one actually, it's you take 2D images, you feed them to the machine learning model, and then construct the all 3D images for the house. This is all AI generated based on just the photos that you take, and actually can generate its own images. Can you click on the second one? This is actually, the second one is more interesting. So this is what generative AI, we talked about text to image and text to video. Now you can see here, for example, you can provide text to say, write something here, give me a mountain, for example. Just provide the text, and it drew the mountain for you. And this is happening today. This is not science fiction. It's already happening. Draw a lake for you, draw some leaves, and this is, again, taking some of the prompts and drew this, and now you have the entire video generated by AI. So this is another important research came out of Meta. So what they did in this research, actually they said that it's for people with a brain injury. So what they did, they took first model, sound to text. So the model actually can take sound and transcribe that to text. The second model on the left, using MEG. So this is like magnetic electron, like EEG of the brain. This is an image to text. So they combine those models between sound and image to provide a text, and then they put the electrode on the brain, and what they were able to do, you have the patient listen to music, and the machine transcribe the music that the patient is thinking of. And they did the same thing on the right where they use a FLAIR MRI. In other words, you can read what people, if you put electrode on their brain, what they can do in the brain or they listen to based on the changes in the model. Now you can see this research where it's going to go, and especially in the future if governments have some of that type of research. But this is just the tip of the iceberg of where this technology can go. And I would argue today that in war of AI, we're in some tasks, we're losing to AI already. And this trend going to continue in the future and probably going to be actually worsening in some of those tasks. So we have to see. So why ChatGPT was special? Because if you think about this product, this is the first time in human history that a product reached 100 million users around the world in 5 days. You can look at the right, even Facebook, Instagram, all of this stuff never achieved that. And OpenAI probably now get more than 1 billion visits, and over 60% of ChatGPT social traffic come from YouTube, and probably 85% of the traffic come outside of the United States, so there's a lot of use. So what can you do with ChatGPT, which has now become like sort of the image of generative AI? There's a lot of things we can do. Actually, you can use it as a chatbot to ask questions. Patients, especially in the United States, they start using it, which is actually dangerous because the information sometimes is wrong. And then you can actually ask ChatGPT to write a research paper for you. Just be careful, because there are some journals that start recognizing that you have to disclose if ChatGPT help you to write this. ChatGPT cannot be an author on the paper, although it's been tried before, but now most journals, even if you look at ASH policy now, you cannot put ChatGPT as an author, which is not fair, because there are some ghost authors that you can put, but you can't put ChatGPT as an author. There's a lot of opportunity for productivity using the system. I just want to mention this research, just to be careful when you're using the system, because the problem with the ChatGPT, it can give you very compelling answer, but fundamentally completely wrong. So what they did here, they used ChatGPT to answer questions from about cancer patients. And what they found actually that about 12 to 15% those answers are actually not related to the NCCN guidelines or any guidelines. So it can be actually sort of dangerous system to use, and there's still a lot of challenges, especially in healthcare, that we have to overcome when we're using the technology. So first is the validation and the accuracy of the information. Again, the answer can be very compelling, very nicely written, but fundamentally is wrong. There's biases, actually, there are ways to bias the system in terms of the answer of the systems, and there's a lot of interesting articles about that. And the answer is actually biased toward, if you think about ChatGPT, what they did, they took all the data in the world from like Wikipedia and everything online, and then trained the model. And most of this data comes from the United States, so definitely there is bias against data, for example, coming from the Gulf region, because maybe there's not enough data in that to train this model there. Privacy is a big issue. Anything you put on ChatGPT, they take it and retrain the model, so anything related to your hospital, related to patients, you shouldn't be doing or putting on ChatGPT, because you're exposing this information externally. And more importantly, it costs about $700 million to operate ChatGPT per day, and the cost of carbon emission just from operating ChatGPT is humongous, and nobody talk about this, obviously. So finally, I want to talk about one very important thing, and the problem that we have in AI in healthcare today is the lack of talent. And how can we build the future of doctors and physicians that actually can be able to speak the two languages, the healthcare and AI language. So this is an initiative we have put together to kind of try to provide some courses that enable you to actually learn about machine learning. One of them will be no-code, low-code machine learning. There's one course about ChatGPT, and you can see the global interest in this website is globally around the world. So I really encourage you to kind of go online and try some of those courses. So in conclusion, AI is changing our lives. You're already using AI every day. I think generative AI will change our life for sure. There will be multiple jobs either eliminated or redesigned. And I think AI will have significant impact on healthcare, but we just have to know how to use it. And I'll leave you with this final conclusion. The electric light didn't come from the continuous improvement of candles. So if we really want to change healthcare, we really need to embrace the technology and take the full advantage of it to apply it to our patients. So again, thank you very much for the opportunity to be here.